We're back to Strategy Room. This is Morning Click. This is Dr. Marc Siegel. I'm in for Harris Faulkner. I'm really pleased today to bring in Samadi, Dr. David Samadi. He's a Fox News medical contributor, and he's the chief of robotics at Mount Sinai Medical Center. One of the reasons I asked him to be here was to talk about an article that was in the New York Times on Sunday about robotic surgery, about prostate surgery in general. But before we get to that, David, I want to talk a little bit about Bill Clinton, because one of the issues that you and I have been talking a lot about is, how do you decide what's good medical treatment? How do you decide whether to use the latest technology or not? You know, Bill Clinton got 2 cardiac stents put into a artery next to a bypass graft that clotted off.
Right.
Now, the bypass graft probably clotted off over some period of time. And I don't think that this was really an emergency procedure, although he had some chest pain. Here's the point I'm making. If it's not an emergency procedure, and he isn't the former president, would he have gotten these stents in a country like Canada or Great Britain? We have over 1 million cardiac stents put in the United States every year. Canada, only 90,000. There's long waiting lines in a lot of the provinces. In Britain, it's even harder. What do you think about that? Do you think that he would have gotten the stents? And if not, what's your opinion?
Okay, here's the situation. As you know, I've done fellowship training in Europe. I worked in France for about a year. I've done some training in England, in London, and I've been here for many years and did all of my training in residency, fellowship, and training in this country. So I kind of have seen some of the contrast between the healthcare in this country and other countries. And I think your point is well taken. Of course, the fact that he is a president, was our ex-president, he gets more VIP status, and he would be able to get in this kind of treatment anytime. I still, despite what's all said and done in the past, I think we have the best healthcare system in the U.S. And prostate cancer or heart disease, these are the leading cause of death, cancer and heart disease in this country. We've come a long way. I'm very happy to see that he was able to come in and get the treatment, even though it was elective, and be back to work. That's really the fortune that we have in this country. What is a good medicine? A good medicine is something that can prolong life, quality of life, save lives. That's what we have in cardiac disease. Even though we don't have a cure, we have excellent treatment options. We don't have a cure for it yet because it's a progressive disease. The natural history of cardiac disease is that progresses. You always want to look at the risk factors, and we've talked about this on Fox News in the past. But recently there has been a lot of discussion about prostate cancer and the use of technology with prostate cancer. And it's unfortunate that vehicles like New York Times is playing a little bit of politics when it comes to this.
I want to get to that in a second, especially that issue of politics. I want to ask you, though, one further question on the stent issue, which is that there was a trial back in 2008 called the Courage Trial. And I'm going to relate this to the prostate. But the Courage Trial basically looked at healthy people that have heart disease. Do you put a stent in them, or do you treat them medically? I'll tell you how I think this is related to the prostate in a minute. I have a problem with that study because it cherry-picked a lot of the people that were in it, and it drew a conclusion that stents did not prolong life in healthy people. It left out the art of the practitioner, the art of the person doing the procedure, and it bottom-lined everything. And I think that that Courage Trial is what we're calling comparative effectiveness that's going to be used if health reform passes in some form to prevent the regular use of stents. What do you think about the place for an artist or a skillful practitioner putting in cardiac stents?
I think it's a very valuable point. I think when we talk about cardiac stent or even cardiac surgery, Mark, the person behind this, and the bottom line after all the debates, after looking at all the data, it really comes down to the fact that the person behind these procedures, the person behind all of these stents or robotic surgeries or cardiac bypass, it's the experience and the art of the person who is doing it. Surgery requires, or any procedures requires a lot of finesse. I always tell my patients that, I'm always there for the procedure from the beginning to the end. And I'm one of the surgeons who is absolutely against running 2 rooms at the same time and do massive number of volumes, because you're not going to give 100% of your attention to your patients. So I think whether it's cardiac stent or it's cardiac surgery or prostate surgery, there is an art to it, there's a finesse to it, It requires the person or the surgeon to be 100% there. That's why the individualized care, the personal touch medicine is what people are really looking for. It's the best quality of care that we can give rather than the mass volume and treat these guys like a number. And that doesn't make any sense.
You know, Tom in Colorado writes something that will lead me to pay you a big compliment. He thinks that the craft side of society, not the high-powered science side, not the research side, but the craft side of industry, technicians, people that are technically skilled, is being overlooked right now in the United States. And the compliment I want to pay you is that I firmly believe not only do you have a big background in surgery and in oncology, but you're a craftsman with the robot. Do you think that that's the most important fact that's being overlooked right now?
Thank you, Mark, for the compliment, and I appreciate the email from Tom. You have to understand, whether it has to do with my background or the way I grew up, part of the things that I tell my patient is that while we do robotic surgery, you have to be a human being. You have to have a big heart. You have to be compassionate about what you do. And it's true that I'm on call for my patients 24 hours, 7 days a week.
I can attest to that. And you also made a point, by the way, about a very important point about operating rooms that our viewers should know, which is there's a lot of surgeons out there that set up 6 ORs at once and go from one to the other, but you concentrate on one case at a time.
Absolutely. That's what the patients want. Every one of my patients, they know that I'm there 100%. I make the skin incision, and I'm there when I close it, and I do the entire case. That's very critical. And I think when we talk about some of this technology, as the email came in, you can't be, as a surgeon, just a technician. That's not what the patient wants. They want that personal touch. Behind these prostates, there are wives, there are spouses, there are children. There's a lot of emotion involved. So don't tell me that in 6 years you can do 3,500 cases and you can do 6 cases a day, as it was coded in the article, and you can have good quality. The data has to be registered. We need to look at the research. We need to look at 3 things: continence, sexual function, and cancer cure rate. That's what the patients want. And they want 100% focus of the surgeon before, during, and after. That's why I'm not a big fan of having fellows see my patients before and after and come in for 15, 20 minutes of fame. I don't think that's good medicine. And what that does, it opens the door for criticism from the open surgeons or laparoscopic surgeons. Bottom line, Mark, what it comes down to, whether you're an excellent open surgeon or you're an excellent laparoscopic surgeon or a robotic surgeon, the outcome and evidence-based medicine is what we're looking for. And if you're good at it, that's where you should go. I always tell also my patients that if you have an experienced artist, open surgeon, and you have the average robotic surgeon, don't take a chance. Go for open surgery. If you have an experienced robotic surgeon, and they really have gone through oncology training, laparoscopic training, and they use the robot as a tool, only as a tool, as a microscope with a big light that can give you extra things that we didn't have in open surgery, then that's where I would go, because I don't think there's any reason to open someone up, to go through all that blood loss. The tactile feedback or the touch factor is gone because now you can see what you're doing. But ultimately, it's the technique and the style of the surgeon and what he does in the operating room is what patients are looking for.
By the way, David, just so our viewers are clear on this, what we're actually discussing is an article that was in the New York Times Sunday that seemed to be implying that robotic prostate surgery which is done in 85% of the cases right now, is a very expensive surgery that is basically unproven. And I feel, and David feels, that there's a political agenda there to reduce the use of the most expensive technologies in the direction of a one-size-fits-all solution, which would be in keeping with health reform or the direction of health reform. They should state that flat out in the article, but they hide it. And we feel, or David feels as an expert in this, that the article is inaccurate in that way. David, would you also describe for people what exactly robotic prostate surgery is, and then answer the question of what you feel was wrong about that article?
Well, robotic surgery involves using the DaVinci robot, and it's a remote control surgery. Surgeon sits about 8 to 10 feet away from the patient, and after you put in the trocars or the keyhole opening and you connect the robot, now you can do the rest of the operation from remote control, 10 feet away. Now, why are we doing this? Because you have 10 to 15 times magnification, whereas in laparoscopy we had 7 times magnification, and in open surgery we had only 2.5 times magnification with the loop. So that's a major advantage. Second is,
you can see the surgical field.
Exactly right. Because there's no blood in the field, you don't have to put your hands there anymore. 75% of the patients that come and see us with prostate cancer in 2010 are what we call a T1C, or a smooth or no nodules. So there's nothing to touch. And
without your hands there, is the risk of infection lower?
Of course it is, to the surgeon and to the patient, because you're not opening up and the risk of infection is much less. Now, having said that, when you don't have any blood in the field and you can see, you have absolutely no reason to have your hands there. In fact, your hands can block your view of your operation. It's not good enough to be either or. It's important to have all expertise in one head. I'll tell you why. In open surgery, as retropubic prostatectomy, you go from the tip of the prostate all the way to the base of the prostate at the bladder. In robotic surgery...
Well, retropubic means going behind the pubic bone from here,
That's
right?
exactly right. In robotic surgery, you go from the base of the prostate to the tip of the prostate. So it's almost reversed. And what makes this transition is to really have the laparoscopic skills. When you have all of that, it makes a lot of sense. What I liked about the article is that they talked about the surgeon who was doing laparoscopic prostatectomy. Now, laparoscopic prostatectomy involves surgeon being next to the patient using long laparoscopic instruments, just like the way we took the gallbladder to do the surgery.
With Martha's gallbladder, they used a scope.
That's right.
You stick in a scope and it has a camera on it.
Exactly right.
But that's not robotics.
That's right. That's only laparoscopic surgery. But this laparoscopic surgeon went to do robotic surgery, and he realized that his outcome wasn't that great, and he went back. And I admire that, because ultimately, as a surgeon, you have to be honest with yourself first. Am I getting the right outcome? We have a lot of open surgeons right now in the field that they're panicking because the number of their prostate cancer cases are going down, and they're jumping on this technology, and no one will give them any credit. If you're going to do a good open surgery and now you're converting it into a 9-hour robotic prostatectomy, that doesn't make any sense.
David, you've told a story about that I'm not sure you can repeat on the air, of an example of someone who did just that, who went from being an okay open surgeon and tried to become a robotic surgeon and made a disaster out of it. And that's just the kind of person that pads the statistics that end up in the Journal of the American Medical Association. You know, I'm not talking about you may not want to talk about the specific.
No,
person.
I think, look, you have to, as a surgeon, stick to your gun and do what you're really good at. And the patients are going to find you. You know, today in 2010, we have many educated consumers. I'm not worried about those, because they're going to find their way through the right system and to the right doctor. I'm concerned about the ones that they really don't know about what's going on in the field. They feel like there's a robot next to them. Small hospitals are buying them without having a trained surgeons. The company has the monopoly, and they're pushing these robots in even small hospitals, and that's when we're going to have complications and issues. So if you're diagnosed with prostate cancer, what you really need to know is do diligent work. Make sure that you get second opinion. Look at the surgeon and find out if he has fellowship training in oncology, in laparoscopy, and has done enough volume. The volume of the cases that they have done, is it really his volume, or is it something they did in residency or fellowship? That doesn't count.
So I'm going to ask you a very tough question right now. I want to translate this whole thing over to health reform.
Sure.
What do we do in the future? So you have robots, they're expensive, they cost over $1 million. A setting like Mount Sinai Medical Center can spend $20 million, get you in there, get all the best care there. And I'm talking about a competitor of mine, and I'm praising it. But in other words, you have a great setup and you're a great surgeon. You know, we can put that in the major medical centers around the country. So I have two questions related to health reform. What do you do in Podunk Hospital in North Dakota? Number one. And number two, if you have a one-size-fits-all insurance that's low quality, like expanding Medicaid, or like an HMO style, is it going to cover the robot? And if not, is the robot going to become extinct before its time?
Well, the question is exactly where is this healthcare reform, and where is New York Times going with most of these articles? And if the future means that we're not going to cover these procedures, and if you want PSA screening for your prostate, we don't think it really adds much to longevity, go ahead, pay for it, or we're not going to cover the robotic surgery, go pay for it. I think that would be not fair to the people who can't really afford this, and they should take advantage of it.
And Tom in Colorado points out that anything that's unproven in the National Health Service in Great Britain isn't covered. So the same point would be here.
I think that would be the danger that we're headed. What I'm concerned about is if a patient is diagnosed, let's say in South Dakota, and he doesn't have access to this kind of expertise, what is he going to do? And I think that robotic surgery should not be done just because you can. Just because you can take a weekend course or practice on someone and you say you take the prostate out, that's really meaningless.
But how are you going to decide what insurance should cover? It should cover David Samadi's procedure. But is it going to cover everyone that's doing robotics? What do you think?
Well, I think what's going to pan out is that there would be like few centers of excellence that are doing large enough number of cases. They can prove that their data is absolutely proven, and patients have to fly in and be able to get those kind of expertise. And the rest of the country over time have to follow the same kind of pattern. It's not just about the robot, Mark. You need to have a team, you need to have expertise, you need to have volume, and you need to be the type of surgeon who really is there 150% for your patients. Then you have the center of excellence. And fortunately, we have that at Mount Sinai, and we're more than happy to guide many patients out there.
David, thanks for coming on. I want to end with an email about you. The doctor understands something very basic. Healthcare is first the treatment of people and their families. Understanding of the soul as well as the body is very important.
100%.
This is Dr. Marc Siegel with Dr. David Samadi. In for Harris Faulkner. Heather North will be next at 10 o'clock. Thanks for watching us. We'll see you next time.
Thank you, Mark.